Greetings from Advanced Fertility and Gynecology Centre. Today we are going to talk about endometriosis. What is endometriosis? Endometriosis is a disorder in which tissues that are normally lining the uterus are present outside in the ovary, in the fallopian tubes, and other areas. The most common symptoms are pain, menstrual irregularities, and associated infertility sometimes. Now, what are the causes of endometriosis? It could be that the menstrual blood, which is supposed to come out, goes back. It's called retrograde menstruation, or the endometrial cells that are producing the tissue for the menstruation is present outside the uterus. It could also disseminate through blood and lymphatic vessels, or it could be an immunological disorder. So endometriosis is known to affect infertility. How does that happen? The fallopian tube, because of the retrograde blood, may get scarred. It can also reduce the egg supply and quality. It can cause inflammation, or it can cause scarring in the tube that prevents the embryo from progressing into the uterus. What are the symptoms of endometriosis? It could be painful menstruation, painful intercourse, excessive bleeding, weakness, infertility, and pain during bowel and bladder emptying. The international guidelines for endometriosis from the European Society has said that the symptoms that I already mentioned, including painful rectal bleeding, blood during urination, shoulder tip pain, pain in the cesarean section site, fatigue, all this can be due to endometriosis. So how do we diagnose endometriosis? Endometriosis can be diagnosed through examination clinically, like a large cyst can be felt abdomen or by internal examination, or the best methodology that has evolved over the past few years is transvaginal ultrasound. It is like the gynecologist and infertility specialist stethoscope. We are able to figure out where the cyst is, what is the size, is there any pain, can it cause, it gives us an idea whether it can cause infertility or not. Sometimes we may need an MRI to look at its exact locations. Sometimes endometriosis is associated with adenomyosis, which is the blood vessels that instead of going outside, go back into the muscle of the uterus. And by the MRI, we are able to pick that up. Blood tests, etc., do not help much in the diagnosis of endometriosis. So endometriosis usually presents as a cyst, and these cysts can be diagnosed by ultrasound. And the ultrasound picture is usually a ground glass appearance, as opposed to clear cyst, which can be because of hemorrhagic cyst, follicular cyst, corpus luteal cyst, and sometimes malignancy. And the way we can differentiate between malignancy and endometriosis is that in malignancy, the cyst may grow fast and there may be a lot of blood flow to it. Laparoscopy is the gold standard. Laparoscopy is a surgical examination, keyhole surgery, whereby introducing a telescope into the abdomen, the gynecologist is able to diagnose and in many cases treat endometriosis. As you see here, endometriosis may not always present as a large cyst. It can also be small spots which can be fulgurated using electric current, and that may reduce pain associated with infertility. Here there is a large cyst, and so is there in the other picture. Now, how do we classify endometriosis? There are lots of classification systems, and it started with the AFS or ASRM system, and then it was the revised system, and then it came into the endometrial fertility index scoring. Now, what is the SRM AFS system? In which once we put in the telescope, we see the size of the cyst, we see how the cyst is adherent to the tube and other structures in the peritoneum. We look for other adhesions and other pinpoint points of endometriosis, and then we divide it into minimal, mild, moderate, and severe, where minimal has 0 to 5 points on scoring and severe has more than 40 points on scoring. Now, endometriosis fertility index scoring was developed by Adamson and Pasta, and he said that, sometimes there may be severe endometriosis on laparoscopy, but the patient conceives easily, naturally. But there may be mild and the patient does not conceive. So just the ASRM scoring is not good enough. We need to find out the potential of a patient after all our tests to get pregnant if infertility is her main symptom. So not only do you see the ASRM findings, AFS scoring, you also do the historical factors like duration of infertility, age, and something called the least function score, where you do the functional scoring of the fallopian tubes, the fimbria, how the attachment of the tubes to the ovary is. Does it look functional? Can it pick up the eggs, or is it mildly dysfunctional? And then there is a scoring that is done, and it is tabulated in this way, where first we are able to see the least function scoring, where we have to see normal, mild dysfunction, and the least score on each side is added. Then we add some historical points like age, and then we add surgical factors like the AFS endometriotic scoring on laparoscopy, and then we find out the total score, which is the historical factors, surgical factors, and that gives the EFI score. And any score that is more than 6 has a good chance of conception. So just to cut it short as to what we discussed, we see the symptoms, we do ultrasound, we do other imaging techniques if needed, we differentiate it between other cysts, and then we do laparoscopy if needed. There is the other scoring of deep endometriosis, which is peritoneal endometriosis, that is also done. And then finally, once the diagnosis is established, we decide to go ahead with the treatment. Now, what is the endometriosis treatment? Treatment can be medical, surgical, or assisted reproduction, which is called MAR, or medically assisted reproduction. Now, what are the medical drug armamentarium that we have? We have hormonal contraception, we have just progestogens, we have GnRH agonist, GnRH antagonist, and aromatase inhibitors. Now, suppose the lady has only pain as a symptoms, okay? Then you have to put in various factors, her age, associated symptoms, and then you have to do a shared decision making as to just give the painkillers, do some hormonal treatment, or does she need surgery? In pain, post-surgery suppression can be given. Now, suppose infertility is the main thing. Usually, suppression is not given, as it just prolongs the time to conception, and that is not advocated. So, either surgery or medically assisted reproduction. And after surgery, whether we should leave or do MAR will depend on EFI scoring. So, endometrial fertility index scoring has come a big way in the management of endometriosis. Now, what is the laparoscopy for endometriosis associated infertility? What do we look for it? So, if we are doing surgical treatment, we have to see, is there associated pain, age, what are her preferences? Is there any history of previous surgery? What is the other infertility factor, including ovarian reserve, male infertility? And then after the laparoscopy, we figure out the EFI. Now, before IVF, if we have decided, say, for example, severe male factor, we have decided for IVF in a case of endometriosis, laparoscopy is usually not needed. However, if there is a huge amount of pain associated, or there's a large cyst that is coming in the way of egg pickup, then we can proceed with laparoscopy before IVF. Now, few points that need to be told to the patient when we are considering laparoscopy. As in the earlier slide, we said that if it is a young patient, then yes. First-time surgery, then yes. In all grades of endometriosis, surgical correction with all other normal parameters can be done. However, it has to be explained that in many cases, because of the peeling of the cyst, the AMH or the ovarian reserve may reduce. And the ovarian reserve must be tested before proceeding with surgery. In women with low AMH, I do not think surgery should be an option, and MAR should be medically assisted reproduction, which is medicines, IUI, IVF should be done. Surgical excision of deep nodular lesions before ART does not improve pregnancy rates. So what is medically assisted reproduction? As we see here, in younger patients with good AMH, good sperm count, IUI can be given. And in compromised tubal function, advanced age, associated male factors, previous treatment which was unsuccessful, IVF ICSI should be offered. Antibiotic prophylaxis should be used at time of oocyte retrieval, especially when there are large cysts, and betadine cleaning of the vagina can be done, followed by a thorough washing with normal saline prior to ovum retrieval. GnRH suppression prior to IVF is recommended for better results. Now, there is thought that if you get pregnant, your endometriosis will reduce. Unfortunately, scientific data has not collaborated on that strongly yet. There is a slightly increased risk of miscarriage and ectopic pregnancy associated with endometriosis. So, on conclusion, we would like to say that endometriosis has a varied presentation. Its main symptoms which come to us are either pain or infertility. We have to identify other factors, mainly tubal factor, ovarian reserve, sperm analysis before we start the treatment. It is usually treatable, so you should not feel morose if you're diagnosed with endometriosis. And all options like medicine, surgery, laparoscopy, ART is available to get you on the road to a pain-free, happy parenthood. Thank you very much.